Hello, my name is Jenny Crisp. I'm a continence advisor and prostate cancer nurse here at Brisbane Urology Clinic, and the purpose of this video is to provide you with some information about your surgery, and hopefully that will help to allay some of your fears and will help with your stay in hospital and your recovery after discharge. The hospital time for this surgery is usually just 2 to 3 nights. When you first arrive at the hospital, you'll be directed up to the day of surgery lounge. That's where the nursing staff will prepare you for theatre. They'll put some theatre clothes on you, and they'll get you to put some TED stockings on, compression stockings. So this is what they look like. And these are very important, obviously one for each leg. Very important because they'll help to maintain your circulation while you are less mobile. Once the TED stockings go on, you then go off to theatre. Theatre time can take 2.5 to 3.5 hours, and then once the surgery is finished, you go to recovery to wake up. That could add another half an hour or an hour, so you could well be away from the ward for 4 to 5 hours. So just make sure your family knows this so they don't worry too much. What to expect when you're back on the ward and more awake and aware of your surroundings. You'll be attached to some equipment, so I'll explain what to expect. You'll have intravenous fluids running for the first day, but usually only for the first 24 hours and then removed, because by the next day you'll be eating and drinking. So as well as that, you'll have sequential compression devices wrapped around your legs. They're like plastic sleeves, if you like. I call them sequential boots. They're wrapped around your legs, hooked up to a pump at the end of the bed, and they pump up and down continuously. And like the compression stockings, those TED stockings we spoke about earlier, they're designed to improve circulation. By maintaining good circulation, hopefully we can prevent the risk of clots forming. So that is pulmonary embolism or deep vein thrombosis. But the sequential boots only need to stay on for the first day that you're in bed. The next day they can come off and you'll just wear your TED stockings. Now, you may have 5 or 6 incisions. If you have a 6th one, it is a drain, and it's your surgeon's preference whether you have a drain or not. If you do, it's usually removed the next day, but sometimes it needs to be left a little longer, so the surgeon will decide on that. You'll have individual dressings over each of your small incisions. They are all waterproof, which means you'll be able to get up and in the shower the next day. And they remain waterproof for usually 3 to 5 days. But once they're lifting at the edges, get them off. There's no need to replace them. Underneath, you'll see that you've got little steri strips keeping the skin edges together. You just leave them alone and they'll wear off. There are no stitches or staples to be removed. Now, the largest of your incisions is right there near the navel. The prostate has been brought out through that incision and then sent off to pathology. You don't get those results while you're in hospital. They'll take a few days, and your surgeon will notify you of those results when they come through. When you arrive back on the ward, you'll have a catheter in place. It's a tube that'll be draining urine from your bladder to the outside into a 2-litre drainage bag on the side of the bed. So I'll just explain how that works. Your catheter has been passed up through the penis and into your bladder. Don't panic, this is a very small model and this is the size of catheter that you'll have in place. So they're going to remove the prostate and the seminal vesicles and the bit of urine tube that runs through the centre, and then join the ends together. So the catheter, while you're in theatre, will be placed in the bladder. When we get the catheter in place, through the side arm or the valve at the side, we get sterile water. I'm just using air because it makes less mess. We then inflate a cuff, which is up inside your bladder, and that's actually what holds it in place, so it's not going to fall out. So when you first wake up with your catheter, it will be draining into a 2-litre bag, which will be hanging on the side of the bed. That's just a urine meter on the front that's measuring how much urine you're putting out each hour. So that's just for the first day, and the urine might be a bit bloody. Don't panic about that. The nurses will be keeping an eye on that for you. Also, it's quite normal to have a hemoserous ooze coming from around the catheter from your penis. Don't panic about that either. Hemoserous ooze is like a pinky discharge. It's quite normal, happens fairly frequently. You just wash off under the shower. So that's the first day that you're in bed. But the next day, so that you can mobilise more easily, the nurse will show you your leg bag. So she's going to place a leg bag, as the name implies. It's strapped to the upper outer part of your leg, like so. Designed for quite large legs. That will mean that you can get up, move around and go to the shower. Once the leg bag goes on, it stays there for the week. You don't disconnect continually to have a shower. Can you see what will happen if you did that? If you keep disconnecting from the leg bag, you're not only leaking urine everywhere, but that's a straight line of infection back up to your bladder. So once the leg bag goes on, it stays there for the week. You don't disconnect to have your shower. You shower with it on. It's just made of plastic, and at the end of the shower you can dry with a towel. The straps dry fairly quickly as well. This leg bag has a tap at the bottom, and that's going to mean that you can go to the toilet and just simply by opening up the tap, empty the urine into the toilet whenever you need to. So you'll be independent by this stage, and you'll be able to do this for yourself. But at night time, you don't want to get up in the middle of the night to empty the leg bag. So the nursing staff will show you how you attach a much simpler 2-litre drainage bag to the bottom of your leg bag and open up the tap. So for night time, it's draining through that bag into the 2-litre bag. In the morning, close the tap off, disconnect, take that bag to the toilet, empty the urine into the toilet, and then dispose of it in the bin. It's single use, and you'll be given a supply of these to tide you over until you come back to have the catheter removed a week later. The catheter is not going to fall out. So while for the week that it's in place, it's that inflated cuff that holds it inside your bladder. A week later, when you go back to have the catheter removed, the nurse just puts an empty syringe, a sterile one of course, into that valve at the side. Watch what happens. The cuff comes down, the catheter comes out. It takes seconds. So don't panic about the catheter coming out. Many men do. That's their biggest fear. So there's no need to panic. There's no pain involved, and it takes seconds. We don't need the surgeon to remove it. The nurse will remove it when you go back to have the catheter removed. Now, when you do go back to have the catheter removed, that's referred to as your trial of void in the paperwork. Fancy name, but it means removal of catheter. Now, there can be some abdominal discomfort and wind pain after this surgery. There's far less wound pain than there ever used to be with open radical prostatectomies, but you can get wind pain, and that's because they use carbon dioxide to inflate your abdominal cavity for the procedure. Now, at the end of the procedure, when the laparoscope is removed, most of the carbon dioxide escapes. But the residual gas can cause discomfort. So that carbon dioxide eventually will escape from your body through a process of respiration. Once it's been reabsorbed by your tissues, you'll breathe it out. It's just that remaining small amount of carbon dioxide that causes the discomfort. And just occasionally, a man might experience shoulder tip pain, and you think, how is that related to the abdominal discomfort? Well, it too can be caused by that residual carbon dioxide. Now, if you were to experience shoulder tip pain, I would suggest let the nursing staff know, because they need to assess you and just make sure it's discomfort from wind and not you having a heart attack. So they'll keep an eye on you. Any sort of major surgery is also going to slow your gut down, and that will increase your discomfort as well. You'll certainly feel better once you start to pass wind and have your bowels open. It's not necessary to have your bowels open before leaving hospital, but the nursing staff would want to know that you're passing wind. Movicol is useful to help to get your bowels moving, and it's a powder. It comes in a sachet form. You mix the powder with a full glass of water and have it near a meal time, either just before or just after a meal. Probably the best meal of the day to start with is breakfast, because that's when we normally have our bowels open. You would have the powder mixed with water, have it just before or just after breakfast. You can ask the nursing staff on the day of discharge, if you haven't already had your bowels open, for a dose of Movicol. Normally we would have our bowels open after we eat and drink, particularly with if you have a hot drink. That's probably the best time of the day to start. So first dose at breakfast time, but if that doesn't work, that's okay. You repeat the steps again at lunchtime and then again at dinner time if necessary. The powder from the sachet is mixed with a glass of water, and you have it just before or just after a meal. Have a hot drink with the meal. You can keep going until your bowels are open, but you just use it as and when required. And if you're going to continue to use this product after leaving hospital, please follow the instructions. Just use it as and when required. And there's no point in doubling up the sachets of powder. For every sachet of powder, it needs to be mixed with a glass of water. There are many brands of equivalent product out there in the marketplace now, because Movicol has recently gone off patent. So there are a lot of generic versions out there that you can purchase from the chemist. There's no prescription required for this. And I purchased this box of Movicol at my local supermarket. I don't guarantee you'll get it at every supermarket, but in the bigger supermarkets it should be available now. While in hospital, you'll be given daily heparin or Clexane injections, and they, like the compression stockings, the TED stockings, and the sequential compression devices, are all designed to help prevent clots. So the injection you get will either be Clexane or heparin. It's going to be your surgeon's preference as to which you receive, but they both do the same thing. They help prevent the formation of clots. Now, it's also your surgeon's preference whether those injections will need to be continued after discharge. If your surgeon wishes you to continue the injections after discharge for a short period, it's usually 2 weeks after surgery, then the nursing staff will demonstrate how to self-administer. It's just a tiny little injection, like giving yourself insulin. It's that tiny, it's pre-filled, and you just pop it into your abdomen. If you're going to continue to use the injections after discharge, the nurses will provide you with your supply of injections and a sharps container on discharge. So after 2 or 3 nights in hospital, you'll go home with your catheter still in place, your sharps container and supply of injections, if that's required, if you're going to continue the injections, and your supply of 2-litre bags. So your trial avoid. The catheter needs to stay in place for a week. As we said before, the catheter needs to be there because the prostate and seminal vesicles and the small amount of urethra that runs through the centre of it have all been removed, and the bladder neck is joined to the remaining part of the urethra. So that's why the catheter needs to be there for a week while that join or anastomosis heals. But a week later, you'll go back to the hospital for the trial avoid. Now, trial avoid is just a fancy way of saying your removal of catheter, but that's how it's referred to in your paperwork. So that's what that means. Trial avoid means removing the catheter. So that appointment is always an early morning appointment. As I said before, it takes seconds to get the catheter out. The nurse simply puts the empty syringe back into the valve at the side of the catheter. The cuff deflates and the catheter comes out. It takes seconds. So you might be asking, well, why do I need to be there for a few hours if it takes seconds to get the catheter out? That's because while you've had a catheter in place, your bladder has been kept empty. Once the catheter is removed, then your bladder goes back to filling and emptying the way it did before surgery. So what you'll have to do then is to sit around, drink quite a bit of fluid. The nursing staff are waiting for your bladder to fill. You go to the toilet once you feel the need, and then they're going to scan you using a bladder scanner. That's just like a mini ultrasound machine. They'll need to repeat that process, you filling, emptying, being scanned. That will all have to be repeated several times because the nursing staff need to know that your bladder is working efficiently. If you're going to book a flight home after the catheter removal, after your trial avoid, I would advise that you book the flight for the following day, just because you may be held up at the hospital for a few hours on the day of the catheter removal. So flights home, better off to be booked the following day. And also, if you're going to have the catheter removed elsewhere other than Greenslopes Private Hospital, then first of all you need to make sure that your surgeon is happy with that, and you'll need to make those arrangements yourself. Driving after surgery. You shouldn't drive for the first week after this surgery, but your surgeon may prefer that you wait 2 weeks before you start to drive again. But that just means shorter distances to start with, no long distance travel. If you have any long distance travel plans, you need to discuss that before your surgery with your surgeon to see what arrangements can be made. Your TED stockings. There's always a slight increased risk of developing a DVT or a PE. Remember, DVT is a deep vein thrombosis, a PE is a pulmonary embolism, and there's a slight risk for about 4 to 6 weeks after any sort of major surgery. After that time frame, your risk drops down to the same as the rest of us in the population. So you need to be careful in that first 4 to 6 weeks after discharge. So if you're going to be sedentary for long periods, you should probably have your TED stockings on. By that I mean sitting around for long periods, perhaps having a very quiet day at home, just watching television all day, or maybe travelling, and travelling in particular, if travelling in a car or a train or a plane for lengthy distances, you will need to have the TED stockings on during those times, and you'll need to get up and stretch your legs every hour. And unfortunately, with car travel, that's going to mean stopping the car, getting out and stretching your legs every hour. Urine leakage or urinary incontinence after surgery. The amount of leakage that you may experience is very difficult to predict before surgery. Some men have minimal incontinence after surgery, but others unfortunately are not so lucky. I've seen some men that have virtually not needed to wear a pad at all, but I have seen a couple of men that have been very, very leaky. Most of you fall in the middle of those two extremes. Why does leakage occur after this surgery? Well, at surgery, the prostate has been removed and the seminal vesicles and the little bit of urine tube, the urethra that runs through the centre, and then the bladder neck and the remaining part of the urethra are brought together and joined. That's your anastomosis. But currently, you've got two sphincters, and that's what keeps you dry at the moment. So you've got an internal sphincter and an external sphincter, and together they keep you dry. And if you think of them like tap washers, one of those tap washers is going to sustain some damage at surgery. So the internal sphincter sustains some damage at surgery. It does not repair, but by doing your pelvic exercises, you can help to strengthen up the remaining tap washer. So what sort of things might make me leak urine after this surgery, you might be asking. Anything that increases your intra-abdominal pressure might make you leak urine. So it could be coughing, sneezing, laughing, hopping, skipping, jumping, bending over to do your shoelaces up, reaching up to get something off the top shelf, putting something in the boot of the car. But it might be something as simple as getting up out of a chair or getting up out of bed. All of those sorts of things increase the intra-abdominal pressure. The pressure is transferred down onto that area where there's been some damage, and that's what might make you leak urine. So you're less likely to leak urine when you're resting in a chair or resting in bed, but you might leak urine as you go to get up out of bed and get to the toilet, that's when there's an increase in the intra-abdominal pressure. So you might consider wearing a pad to bed at night. It's not so much to protect you while you're lying in bed. When you're resting quietly, there's minimal risk of leakage. It's when you go to get out of bed and get to the toilet that you might leak, and that's where you need your pad. So wear a pad to bed at night to start with, till you work out how much leakage you may be experiencing. So how can the pelvic floor exercises help? Well, they're going to strengthen up the remaining sphincter, if you like, that remaining tap washer. They are very, very important. I mean, it's obvious how important they are. If one's damaged, you had two, one's damaged, and you're left with one, it makes sense to strengthen up the remaining sphincter. Start today. Start your pelvic exercises today. Don't do them while you've got a catheter in. You'll have a catheter there for a week, but resume them a day or so after the catheter comes out. And I would suggest you go onto our website and watch the video on how to do your pelvic exercises. On the website, they'll show you not only how to perform a pelvic floor exercise, but how many in a day, a sensible regime. So don't overdo them. There's no point in overdoing your pelvic floor exercises. What you are exercising is voluntary muscle, so like the muscles in your arms and legs. If you overdid exercise in your arms and legs, what are your arms and legs going to feel like at the end of the day? Sore? Are they going to be able to work as well? No, probably not. So what happens to these fellows that overdo it? They get so keen and so, motivated to fix the urinary incontinence, that if I suggest they do their exercises 3 times a day, they'll do them 12 times a day. And what they're doing is fatiguing that muscle, and so it doesn't work as well because the muscle is fatigued, and as a result, the man will leak more urine. So not only will he leak more urine, but he'll feel really sore in the perineal area. So he'll have to back off, stop the exercises for a few days till everything settles, and then resume them at a sensible rate. So just follow the routine on the website. So pelvic floor exercises are plan A, if you like, to regain your urinary control. But it takes time, and it might take somewhere between 6 weeks and 6 months before you're dry. But there's usually a fairly significant improvement in the first 3 months after surgery. Worst case scenario, after 9 or 12 months, maybe the leakage had improved a bit, but you still needed to wear a pad. That doesn't mean that you have to wear a pad for the rest of your life. We can think then about continence surgery. Continence surgery is a type of surgery that's been around for many years. They've been doing it for women for many, many years because often we're the ones that are incontinent after childbirth. And now that type of surgery has been adapted for men, and it works really well. And then some men will say to me, well, why don't they do that at the same time as they do the initial surgery? Then I don't have to worry about all this nonsense of pelvic floor exercises and pads, etc. And the reason is, most of you don't need it. Most of you are going to get dry without it. Fluids. Some men have the mistaken idea that less in equals less out. They seem to think that if they really restrict their fluid intake, that they'll leak less. But that doesn't work, because if you restrict your fluids to that extent, you get dehydrated. If you get dehydrated, you get constipated. If you get constipated, you will leak more urine. So no point in doing that. You need to drink. But there's no magic amount you need to drink. There's no magic formula. It's a myth to think that we all need to drink 2 to 3 litres of water a day. It's really a matter of keeping your urine a straw colour. It doesn't need to look like water coming out of a tap. So, just remain adequately hydrated, but no magic formula. So even if a nurse instructs you on discharge from hospital that you need to drink 2 to 3 litres of water a day, it really isn't necessary. Just keep your urine a straw colour and you're on the right track. Now, some fluids might increase your risk of incontinence, urine leakage. That's not to say I'm asking you to cut them out. I'm not even suggesting you cut them back. All I would suggest, though, is that you might want to experiment with these things at home first to see whether they're going to pose much of a risk of leaking urine. And the things I'm talking about, you probably already know what I'm about to say, are all the caffeine-containing drinks like coffee, tea, cola drinks, energy drinks that contain caffeine, and the other big culprit can be alcohol. Now, the caffeine-containing drinks, the reason that they may increase the risk of leakage is that caffeine is a diuretic. It makes your kidneys produce a bigger volume of urine. Not only that, but caffeine can be a bladder irritant. It's fairly acidic and can irritate your bladder and make you feel like you want to pass urine frequently, even if there's not a big volume there. Alcohol is also a diuretic, so it makes your kidneys produce a bigger volume of urine. But also, it's a bit like drinking and driving in that it slows your response rate down. And I have to say, over the years that I've been doing this job, probably more men have complained about the alcohol than they have the coffee, tea, cola or energy drinks. But just experiment at home, where you know where the bathroom is, you can get a change of pad if you need to, and it could potentially save some embarrassment when you're out and about. The next thing to talk about are good bladder habits and going to the toilet all the time, just in case. Many women have developed bad habits like this over the years because we're usually the ones that have some incontinence after childbirth. And it is tempting. There's a temptation to go to the toilet a lot more frequently after this surgery because there is that risk of leaking. And the idea being that if I go to the toilet very frequently and keep emptying my bladder, that is going to save me leaking urine further down the track. But it doesn't, because most of us don't empty our bladder out completely anyway. So you could be going to the toilet every half hour or so, for example, come out of the toilet, cough, sneeze, laugh, or bend over to do your shoelaces up, and you could still leak some urine. So it hasn't solved the problem. It's just that if you keep doing that for long enough, the bladder becomes less compliant. By that I mean it just becomes a little lazy and gets used to operating on smaller volumes, and rather than being able to fill to say 200 to 300 mils as your bladder probably does now. So if you've got reasonable bladder habits now, don't change them. But having said that, it's reasonable to go to the toilet before you go to bed at night, before you get on a bus or a plane or a train for a lengthy trip. We all do that. That's fine. Continence pads. What do I need to buy? Where do I buy them? And how many pads will I need per day? So there are many good brands of continence pads out there in the marketplace. You can purchase continence pads at a chemist shop, chemist warehouses, any of the discount pharmacies. There are companies that will even deliver to your door that are on the internet, like In Touch, Independence Australia, or Bright Sky. Woolworths has their own brand now, so do Aldi. But both Woolworths and Aldi have a fairly small range of pads as far as I've been able to ascertain when I've been looking in the supermarkets. But do be careful, because you don't want to be buying a Modes pad. A Modes pad is designed for a thicker, more viscous loss. It won't cope with the faster flow of urine. It's a completely different pad. It's designed for female menstruation, so avoid those. But you don't need to find a pad necessarily that's designed specifically for a man. That's a tenner for men level 2. Wide a bit at the front, you can see how that works. You peel the paper off, reveals a sticky surface, and that's what adheres it to your undies and stops it moving around. But this is a tenner pad extra. Nothing wrong with a male wearing this. He just pulls it up a bit more towards the front because he's got a different direction of urine flow. Same thing, same product. Peel the paper off. Sticky surface holds it in place. You need to find a pad that you're not changing any more than maximum 4 times a day. If you're changing more than that, either one of 2 things is possibly happening. Either one, perhaps you're changing your pad unnecessarily and perhaps wasting your money, or 2, you need to find a pad that's got a greater capacity. So you know when you need to change a pad when it stays wet on the surface next to your skin. Once it stays wet on the surface next to your skin, it is saturated and you'll need to change it then, otherwise you'll get red and excoriated. That's just like nappy rash. Boxer style underwear won't hold your pad in place. because of the loose leg. You'll need to wear, while ever you're wearing continence pads anyway, you'll need to wear Y-fronts or jockeys. Continence pads have a code, and the more of the code coloured in, the more urine it will hold. And the code ranges from 1/2 to 8. So let me show you. This is a tenner for men level 2. And we've got 4 droplets of water coloured in. So that's telling you the capacity of the pad. So that's tenner for men. Then we have a tenner pad extra. Again, it's got 4 droplets of water, 4 of the code coloured in. But the depend guards for men have squares coloured in. So you can see the squares. So 4 squares is the same as 4 drops of water. So that one equates to those two as well. Just a different symbol, but if it's the same amount coloured in, it's the same capacity. Now, I picked these up only last week, and Poise pads used to have circles coloured in. Same thing again, the more of the code coloured in, the thicker the pad. But see, they've changed to droplets of water, and I believe that's how all continence pads are going to go eventually. So just be mindful that if you are purchasing a Poise pad, it may, depending on how new the packaging is, it may be circles coloured in or droplets of water coloured in. Same thing, you know, the same number coloured in, the same capacity. So just to go over that again, all continence pads are going to have a coding system on the packaging, and the coding will range from 1/2 a code all the way up to 8, and that represents the amount of urine it can hold. So as the number of codes increases, the number of codes that are coloured in, that is, increases, the pad can hold more urine, and it's going to go from 1/2 all the way up to 8. Now the code may be a droplet of water, a circle or a square, but the more coloured in, the more urine that the pad can absorb. Because we have no way of knowing how much urine you might leak after this surgery, it's not a bad idea to have just maybe 1 or 2 packets of mid-range pads on hand. Not a lot, but just maybe 1 or 2. And it can be any of the continence pads, but if you're looking in your supermarket, it could be a tenner for men level 2, it could be a tenner pad extra, or a depend guards for men, or a Poise pad extra. All of these are mid-range pads, and that gives you your starting point then. So from that point, you can either work up or down in capacity to meet your needs. So maybe to start with, you might need to increase the capacity of the pad for a little while, but eventually, hopefully, you're going to decrease the capacity of the pad. And that's the idea of starting mid-range. Erectile function. Your erectile function will definitely be affected after this surgery, and there's no guarantee how much, if any, you will regain. So do remember though, you won't produce ejaculate, and that's irrespective of what nerve sparing can be done. You won't produce ejaculate after this surgery because the seminal vesicles have been removed. Don't panic though, and don't feel too depressed. Some men do, because they think, well, that's the end of them ever being able to climax or reach orgasm. Remember, orgasm is something that happens in your brain, not the other end of the anatomy. And whether you're producing an ejaculate or not, you can still climax. So even if you've got a very poor erection, you can still climax. It's your brain where that is occurring, not the other end of the anatomy. So the amount of function that you could possibly regain is going to be dependent on the nerve sparing that's achievable at the time of surgery. The surgeons will always spare nerves wherever it is safe to do so. Sometimes they can do a complete nerve sparing at the time of surgery. Other times, perhaps they can only do a partial nerve spare. And unfortunately, sometimes they can't do any nerve sparing at all. Ask your surgeon while you're still in hospital, and he'll tell you what nerve sparing he was able to achieve. But the best case scenario still does not guarantee you're going to get function back. Some men do slowly recover some function over a 2-year period. They might steadily recover it during that time. Others aren't so lucky. Every man is going to have a different journey. So some men are very keen to regain as much function as is possible, and others aren't concerned. Different men are at different stages of their lives and have different expectations. We don't make judgments here, we're just here to help. The first treatment option for a man who has had some nerve sparing achieved at surgery is going to be one of the oral medications like Viagra or Cialis or Levitra. It is of no benefit though for someone who's had no nerve sparing achieved, and shouldn't be used by someone who takes anginine or glycerol trinitrate for chest pain, as that could prove fatal. Quite often the oral medications are not effective in the first 6 to 12 months, so some men choose to learn how to use the penile injections during this time. The benefit is that the penile injection is a drug that acts locally. So once the correct dosing has been achieved, a man is able to get an erection, even if he's had no nerve sparing, because the drug acts locally and is not dependent on nerve pathways to the brain. Some men can't bear the thought of injecting their penis, so they may opt to use a vacuum erection device. It's another way of getting a type of an erection. It's a personal choice. At the end of 18 months to 2 years, you may decide that you want to have a penile prosthesis implanted. Again, it's personal choice. I suggest you talk to your surgeon about your options at your post-op visit, so that'll be at the 4 to 6 week mark. Until you regain control of urine, there is the possibility of leakage whenever you get sexually aroused. But don't let that stop sexual activity. Just wear a condom. And different positions can affect the amount of leakage, so you might want to experiment there, but there's no need to stop sexual activity. Avoiding the risk of an incisional hernia. After this surgery, you recover very quickly, much faster than you ever did with the open radical prostatectomy. There's less wound pain, you feel well, you're back to doing your normal day-to-day activities. And because you feel so well, there is a temptation to do too much too soon. Certainly you can resume all your day-to-day activities. What I'm talking about is strenuous activity or really heavy lifting. That's what might increase your risk of getting an incisional hernia. That's a hernia at the site near the umbilicus. That's where the prostate has been removed. If you do any really strenuous activity, for example, like going back to lifting weights at a gym, lifting bags of cement, pushing a lawnmower up a hill, you do any of those sorts of activities in the first 3 months after surgery, you are increasing your risk of developing an incisional hernia, and that will mean going back to hospital for another lot of surgery to have it repaired. But normal day-to-day activities are fine, and walking is a great form of exercise. There's no problem with that at all. If your work or any of your recreational activities involve a strenuous activity or heavy lifting, discuss it with your surgeon. Finally, if you have any questions or concerns after watching this video, please feel free to contact us. Thank you.